the field of the congenitally malformed heart. Well, since then, Meryl and I have been discussing how we can acknowledge the huge contributions made by Paul, and in so doing, we've also been able to resolve the potential differences we had with our description of the functionally univentricular heart. And in fact, we were both trying to say the same thing, but as is so often the case, we stumbled because we were using different words. So Meryl tells me that she was trying to emphasize that when you as clinicians come across functionally univentricular hearts in which ventricular septum is deficient, then if the communication between the ventricular chambers becomes obstructed, then oftentimes that presents to you as coarctation or interruption of the aortic arch. And as clinicians, you need to bring this key feature to the attention of your surgeons. Now, in fact, that detail was exactly what I was trying to emphasize when I discussed with you the groups of patients that make up the functionally univentricular heart, because we only find ventricular septal defects or interventricular communications when the insult producing the functionally univentricular arrangement has occurred during development prior to closure of the embryonic interventricular communication. And I emphasize that difference by talking to you about acquired disease of fetal life that produced hyperplastic left heart syndrome and some examples of pulmonary atresia with intact ventricular septum. So we were trying to say the same thing, and all I was emphasizing is that even when you come across examples of the functionally univentricular heart in which there is an interventricular communication, the very fact that there is an interventricular communication tells you that you are dealing with right and left ventricles with a communication between them, but that one or other of those ventricles is not only hypoplastic, but is also incomplete. So I hope we have resolved the potential differences that may have existed. And I can tell you with confidence that there is going to be no differences between the approach taken by Dr. Cohen and myself when today and next week we separately discuss the issue of heterotaxy as opposed to isomerism. So today I'm going to start that discussion by presenting to you the anatomic evidence concerning the relationship between so-called heterotaxy and isomerism.
Christy.
Welcome to Congenital Heart Academy. We are happy to have all of you. I'm Egrid from Brazil. I'm Brazilian delegate, and I'm happy to present the next activities. Next week, we have other class with Professor Meryl Cohen, IECO series, Heterotaxy and Isomerism, on 26th of October on Monday. And we have other class of Professor Robert Anderson on 30th of October about the anomalous venous drainage. And the next one, it's about a webinar in 28th in Italian, 3D 4D models in congenital heart disease, how it can change management today and tomorrow. And I'm so glad to introduce Dr. Robert. He's an excellent morphologist, and he will talk about isomerism with us. What is isomerism? Thank you, Dr. Robert.
So if we want to know the meaning of heterotaxy, we can do no better than go to this excellent review, to which I will refer again subsequently, made by Dr. Kim in the Korean Circulation Journal. As you see, it's quite an old publication, but I think it sets the scene for heterotaxy versus isomerism. So as Dr. Kim points out, heterotaxy is a Greek word. It means any pattern of anatomical organization which is not the expected, usual, or normal arrangement. Now, you are all well aware that I like to use words in their meaning to the everyday person. So I think that this definition of heterotaxy given by Dr. Kim is very important as we start today's discussion. Because what it means is that if we take this definition and if we use it literally, then those individuals that have a mirror-imaged arrangement of the organs and hence are other than usual or normal are themselves heterotaxic. Now, why do I emphasize that point? I tell you that because the nomenclature working group that has now produced the definitions and the descriptions that will populate the latest edition of the International Classification of Disease, called ICD-11, the nomenclature working group have also produced a definition for heterotaxy. And they have taken the definition that is usually used by pediatric cardiologists. And they say that heterotaxy is defined as an abnormality when the internal thoracoabdominal organs demonstrate an abnormal arrangement across the left-right axis of the body. Well, this is obviously true, but I draw to your attention that even within that definition, those individuals that have a mirror-imaged arrangement of the organs would still be heterotaxic, because in those individuals, the mirror-imaged arrangement of the organs relative to the left-right axis of the body is itself abnormal, although it is still lateralized. But, for better or worse, the working group chose to exclude mirror imagery from the setting of heterotaxy, and I now wonder whether that is really justified. But let's get down to the definition that the working group provided for heterotaxy, because within that definition, there are still two subsets of patients. So the question we are discussing today, as we consider the relationship between so-called heterotaxy and isomerism, is how best to segregate and describe those two groups that together make up what the working group consider to represent visceral heterotaxy. Now, before we get into that, let's just for a moment consider isomerism. So here on the screen, you see an illustration of what I hope we all understand by isomerism. Where do we find the definition? Nowadays, of course, we go to Wikipedia. And when we look into Wikipedia, we find that isomerism is in fact enantiomerism. And what we see are two stereoisomers that, as Wikipedia says, are related to each other by a reflection. And here is the key. The features we see of isomerism are mirror images of each other, but in the same individual. So now let's go back to Dr. Kim, because he too provided a definition of isomerism. Here you see, we're again back to the Greek, iso meaning equal, meros meaning part. And I think Dr. Kim's definition of isomerism is also very good, because as he says, the term isomerism has become the conventional description for when the morphologically right structures or the morphologically left structures are found on both sides of the body in the same individual. In other words, they are mirror images of each other in the same individual. So let's look for examples of isomerism. Now here I'm showing you the dorsal surface of my own right hand. And there is the dorsal surface of my own left hand. And they are mirror images of each other. So in fact, all we have to do, if we want to find examples of isomerism, is look at our hands. Because the hands, and indeed all the lateralized parts of the body, are examples of isomerism. So we know that the muscular system, the nervous system, the arterial system in everybody is isomeric, because more or less the right side of the body is the mirror image of the left side of the body. But is that also the case for the organs? Do the organs exhibit isomerism? So let's look at the bronchial arrangement. Now here, as is so often the case, I'm indebted to my friend and colleague, Shumpei Mori, cardiologist who was initially working in Kobe, now working at the University of California in Los Angeles. Shumpei has produced these exquisite virtual dissections of normal individuals. So here he is showing you the normal arrangement of the bronchial tree relative to the pulmonary arteries. And what you see is that in the normal individual, the right-sided bronchus is short, and it branches before it is crossed by the pulmonary artery supplying the low lobe of the right lung. So the first branch of the right bronchus is eparterial. It is above the artery. The left bronchus in the normal individual is long, and it is crossed by the pulmonary artery supplying the low lobe of the left lung before it gives its first branch. So the first branch of the left bronchus is hyparterial. It is below the pulmonary artery. If we then look at an individual who has mirror-imaged arrangement of the organs, we see that the bronchial tree is similarly mirror-imaged. So here again, using one of Dr. Mori's beautiful virtual dissections, we see now that it is the right-sided bronchus that is long, and its first branch is again below the pulmonary artery. It is hyparterial. Hyparterial bronchus in the mirror-imaged arrangement is right-sided. So the left-sided bronchus is short, and it gives off its first branch before it is crossed by the pulmonary artery supplying the low lobe of, this time, the left lung. And note also that the long axis of the heart is pointing to the right, because in the mirror-imaged individual, we find the heart located in the right hemithorax with its apex pointing to the right. The cardiac position is also mirror-imaged. But Dr. Shumpei and Dr. Mori can also show us that there are two additional arrangements of the bronchial tree. And these are the arrangements that we find in the setting of so-called heterotaxy. And these arrangements of the bronchial tree begin to show us how we can segregate heterotaxy into additional subsets of right and left isomerism. So in this individual, where again the cardiac apex is pointing to the right, cardiac position, however, tells us nothing about what is going on within the heart, we see that both of the bronchuses are short, but both give off their first branch before they are crossed by the pulmonary arteries supplying the low lobes. In other words, we have right isomerism of the bronchial tree, and we have right isomerism of the pulmonary trunk. And then if we look at the other subsets of individuals that make up the group that the nomenclature group wish to consider as visceral heterotaxy, and we look at the bronchial tree, we see that both the bronchuses are long, both of the bronchuses are crossed by the pulmonary arteries supplying the lower lobes before they give off their first branch. So we have isomeric hyparterial bronchuses. Here we are looking at left isomerism, the second subset of so-called visceral heterotaxy. So now I've shown you that we can identify isomerism in the lungs and in the bronchial tree. But the real question we have to address now is, can we find evidence of isomerism within the heart? And that has been somewhat controversial. And my good friend Richard Van Praag has argued that isomerism is no more than a useful mnemonic, because he suggests that we cannot find isomerism within the heart. So let's now go back and look at the way that the heart develops, because again, we now have evidence from what we know about cardiac development that is pertinent to this debate. So we know that at the early stage, we do have a straight heart tube. And here I'm showing you the situation in the mouse embryo before we have formation of the ventricular loop. Very soon, however, the heart does loop, and we discussed this in our session quite some time ago now when we considered ventricular development. And we know now that having looped, the chambers themselves form by expansion from that primary heart tube, and they do so by a process that we call ballooning. And it is ballooning from the atrial segment of the developing heart that gives us the appendages, whereas in the ventricles, the process of ballooning produces the apical components. And it is not coincidental, as I'm going to show you, that it is according to the appendages or according to the apical components that we distinguish within the heart what is morphologically right as opposed to what is morphologically left. So how does that relate to the considerations of isomerism? Well, this drawing was made by my colleagues in Amsterdam to show the features of ballooning. So what they are showing you here is the bent heart tube with the original heart tube shown in silver. And what they've illustrated here in blue is how the atrial appendages balloon from that atrial component of the heart tube, but they do so in parallel fashion. What they're also showing is that in the ventricular loop, the apical components do not balloon in parallel fashion, they balloon in series. And that is key for the understanding of isomerism within the heart. And that is because we know that it is now genes that influence the heart tube and indeed influence all structures in the body to determine what is morphologically right as opposed to what is morphologically left. And we now call these the laterality genes. And the two key genes are, on the one hand, PITX2. There are a family of PITX2 genes, and they determine what is to be morphologically left. And then there are another group of genes which include lefty1, nodal, sonic hedgehog, also comes into this group. And what these genes do is they create a midline barrier during development, and they stop PITX2 gene reaching the right side. So when all these genes act in harmony, the left side of the body becomes morphologically left. PITX2 does not reach the right side. So the right side of the body then develops its own morphologically rightness. So let's look what would happen at the stage where we have a straight heart tube. We can divide the heart tube into its left side and into its right side. But then you've already seen that the next step of development is ventricular looping. And now there has been a key change because that midline has itself looped. So now when we look at the atrial component of the heart tube, we see that it has a right side and it has a left side. And the right atrial appendage will balloon from that right side. left atrial appendage from that left side, so they will be under the influence of those different genes that produce morphologically rightness as opposed to morphologically leftness. But now look what is happening in the ventricles, because the developing left ventricle itself has its own left side and its own right side, as does the developing right ventricle. So they are going to be the influence of all those genes, not just one of them or the other group. And that is key to determining that in the atrial chambers, we see a difference in the atrial appendages, with the pectinate muscles coming all the way to the crux on the right side, confined within the tubular appendage on the left side, because the two halves of the atrial chambers are exposed to those different genes. And now, when the molecular biologists knock out those genes, and here in this heart that was prepared by my good friend and colleague Nigel Brown from St. George's Hospital, Nigel Brown worked closely with Jim Martin from Houston in Texas, and it was Jim Martin who created this knockout mouse, knocked out PITX2, and I'm showing you this scanning electron micrograph of the underside of the atrial component of the heart, and I hope you will all agree that in this mouse, both of the appendages are morphologically right. So by knocking out the gene that produces morphologically leftness, it's not surprising that we end up with right isomerism. And then we have another set of mice, and these mice were processed in Japan, and the excellent molecular biologists in Japan were able to knock out the gene creating the midline barrier. When you knock out the midline barrier, the PITX2 gene can reach both sides of the developing individual and turn both sides into morphologically left structures. And so here in this mouse, what you see, both of the appendages are tubular. The pectinate muscles are confined within the appendages by knocking out the midline barrier, by letting the gene that produces morphologically leftness affect both sides of the developing individual. Here we have an individual that within the heart, a mouse that has isomeric left atrial appendages. So there is no question that the heart can exhibit isomerism. The molecular biologists have now shown us that, but that, of course, is in the setting of mouse biology. The question for you as clinicians, of course, is can we recognize the isomeric features in the postnatal heart? And can we use the concept of isomerism to separate heterotaxy into its various groups? Well, what I hope I've now shown you is that it is the atrial chambers that show the features of isomerism. So if we are to look for isomerism within the heart, we must concentrate on the atrial chambers. So how do we distinguish rightness from leftness? And that is the key question. And we should do so using what we now call the morphological method. We should identify structures on the basis of their most constant components. And I would remind you that this key concept was introduced by my good friend Richard Van Praag when he criticized one of our own publications that we discussed last week, when I explained to you we were trying to deny ventricular status to the left ventricle in the setting of double inlet right ventricle. And we realized that we were wrong, and so ever since then we have used this concept of the morphological method. So what we have to ask is, what is the most constant atrial component? And here we find it is not necessarily the most obvious, because many still use the venoatrial connections to determine what is morphologically right, what is morphologically left. That's all very well in the normal situation. But let me show you this heart. And many of you will immediately recognize that I am showing you the heart from an individual with totally anomalous pulmonary venous connection. The heart has been flipped out of its pericardial cradle using the so-called Tausig maneuver. And there you see the pulmonary veins. And they are turning south, and they are heading for an extra cardiac site. So if in this individual we were going to use the pulmonary venous connection to determine what was the left atrium, we'd have to end up by saying it was the liver that was the left atrium, because that is where the pulmonary veins drain the pulmonary venous blood. And you immediately see that is a nonsense, because we can still recognize the left atrium even though it lacks its pulmonary venous component. And that is because the venous components are not the most constant atrial components. It is the appendages that are the most constant component. So, can we recognize the morphologically right from the morphologically left atrium if we look at the appendages? Well, in most instances, we can do that simply on shape. So here you see the morphologically right appendage, which looks like the map of India upside down. It's markedly different from the morphologically left appendage, which looks like Snoopy's ear. But my good friend Richard van Prague, again, when we tried to use shape as a distinction of appendages, pointed out that shape can be changed by hemodynamics. Despite that, in the setting of heterotaxy, in many instances, as here, we can see that both the appendages look like the map of India upside down, and they are mirror images of each other. Because in many instances, we can distinguish isomeric appendages according to their shape. But it is true that this sometimes is difficult, even though here I can show you example where unequivocally we have isomeric left appendages as judged on their shape. But is there a better way? Well, accepting what Dr. van Prague said, that shape can be altered by abnormal hemodynamics, my colleagues and I looked for a more reliable means. So we looked for the internal features, and we chose the terminal crest. And we found again that the terminal crest in the setting of isomerism is a useful guide for recognizing isomeric right atrial appendages, and in its absence, recognizing isomeric left appendages. So my other good friend, Hideki Uemura, he was working with me in London in the early 1990s, studied a large group of hearts from patients known to have so-called heterotaxy. And he looked for the features that would identify the atrial chambers as being morphologically right on both sides, morphologically left on both sides, or in which there was uncertainty regarding atrial morphology. And as Dr. van Prague had predicted, when Dr. Uemura was using shape to distinguish rightness from leftness, he was able to do that in many of the hearts, but not in all. When he added to that the internal features, the presence or absence of the terminal crest, he was able to reduce the number of hearts in which there was uncertainty as to whether or not isomerism was present. But that still wasn't good enough to give us an absolute marker of right versus left isomerism. So then Dr. Uemura came up with the key feature that distinguishes what is morphologically right as opposed to what is morphologically left when we look at the atrial appendages. And that feature is the extent of the pectinate muscles relative to the atrioventricular junction. So to your left hand now, you see how in the morphologically right appendage, the pectinate muscles extend all the way around the atrioventricular junction. In the morphologically left atrium, in contrast, the pectinate muscles are confined within the tubular appendage. And then, when Dr. Uemura used this criterion on all 182 hearts coming from individuals known to have heterotaxy, in each case, he was able to distinguish the presence of right versus left isomerism. So now we can say with confidence that if we look at the pectinate muscles, we can distinguish those individuals in whom the atrial appendages are usually arranged, as opposed to those in which the atrial appendages are mirror imaged. And here we see something that is heterotaxic. The mirror imaged arrangement is other than usual. But more importantly, when we analyze the individuals said to have so-called visceral heterotaxy, when we look at the extent of the pectinate muscles, we can divide these individuals into two subsets according to the presence of isomeric right atrial appendages or isomeric left atrial appendages. But here there is a caveat, because the presence of isomerism is not always uniform. So when we try to correlate isomerism within the heart as opposed to the arrangement of the remaining organs, in some instances we have excellent correlation. So with the bronchial tree, there is excellent correlation. With the spleen, which used to be taken as a discriminator for so-called visceral heterotaxy, and for quite some time, visceral heterotaxy was divided into subsets of asplenia or polysplenia. We found that there was good correlation, but it was far from perfect. So let's look at what was going on in the spleen in these individuals that Dr. Uemura had in his group that he had stratified according to the arrangement of the atrial appendages. So here we have the group in which there are isomeric left appendages. And in this instance, we would expect there to be multiple spleens because both sides of the body are developing features of leftness, and the spleen, of course, is a morphologically left structure. But surprisingly, in only 2/3 of these individuals did Dr. Uemura find the presence of multiple spleens. In a small proportion, the spleen was absent, whereas in others, there was a solitary spleen, and in still others, in fact, 1/4 of the cohort, we couldn't determine splenic morphology because we only had the hearts. And when we looked at the other half of the cohort, those in which Dr. Uemura had identified isomeric right appendages, where we were expecting to find absence of the spleen, again, we could only make the distinction in about 3/4 of the cohort because we only had the heart. But in that 3/4, you see that not all had absence of the spleen. Indeed, in a significant proportion, there was a solitary spleen, and in some, there were even multiple spleens. So the presence of isomerism and the presence of the changes in the abdominal organs does not always correlate with what we find within the heart. And even in the heart, there are potential problems because it is only the appendages that are isomeric. But this does not mean we should ignore that. It simply means that having established that we are dealing with isomeric atrial appendages, we then look for and we describe the variables. Perhaps most important, venoatrial connections, but also of significance. What is going on in the ventricles, and then what is going on at the ventriculo-arterial junction. It's important then to state that once we've found isomeric appendages, it only gives us clues to what is going to happen with the venoatrial connections. They need to be described with certainty, and they need to be described so as to remove any ambiguity, because there are still some who would call visceral heterotaxy situs ambiguous. But what I'm going to show you is that when we describe all the features, we take away any considerations of ambiguity. It's also important because in certain individuals with isomeric atrial appendages, the venoatrial connections can be arranged in such a way that the drainage is either quasi-normal or quasi-mirror imaged. So we need to take account of that. But having said that, the overall arrangements differ in fundamental respects between those having right and left isomerism. And these differences in venoatrial connections are usually sufficient for you as clinicians to make a distinction between the two subsets. So, in right isomerism, we anticipate that there will be bilateral superior caval veins. Because of that, always in the setting of right isomerism, there will be absence of the coronary sinus. That means the coronary veins must drain directly to the atrial chambers. Also, since we are dealing with hearts having isomeric right atrial appendages, the pulmonary veins, even if they come back to the heart, will connect anomalously. You cannot have normal pulmonary venoatrial connections if both atrial appendages are morphologically right. In fact, the venoatrial connections are to the systemic veins. In about half the cases, the pulmonary venoatrial connections, about half directly to the heart. When they come to the heart, they rarely direct to the roof of the right-sided atrium, more usually to a midline confluence, but always in the setting of isomeric right atrial appendages, the anatomic connections, even if coming back to the heart, will be abnormal. So what's happening in left isomerism? Again, frequently we find bilateral superior caval veins, but now one will drain to the coronary sinus or will try to drain through the atrioventricular junction, because the coronary sinus is a morphologically left structure. And indeed, if we look in the hearts, we find that both of the superior caval veins, when they are present, are trying to be morphologically left. But on occasion, the coronary sinus will be absent, and then the coronary veins again will drain directly to the atrial chambers. Because we're dealing with isomeric left atrial appendages, however, the pulmonary veins can drain in anatomically normal fashion on either side of the heart, albeit two on each side. So frequently, in the setting of left isomerism, we find symmetrical pulmonary venous connections. But here is the hooker. For individuals with left isomerism, the inferior caval vein is morphologically right. So it is likely to be absent in the setting of left isomerism. So we expect to find interruption, the inferior caval vein, and then the hepatic veins usually drain directly, although on occasion they can drain through an infradiaphragmatic confluence. So in most instances, the arrangement of the venoatrial connections is sufficient for you as clinicians to make a distinction between right and left isomerism. We can then take that knowledge as we look at the atrioventricular junctions, because the atrioventricular connections, when they are biventricular, are mixed. They are not ambiguous, as we used to describe, but on occasion, particularly in right isomerism, both atrial chambers join to the same ventricle. So then we have the univentricular atrioventricular connections, usually double inlet, but on occasion, absence of one or other atrioventricular connections. And this information is key to the organization of the conduction system, because that is greatly influenced by the presence of isomeric appendages. So it is the case that when we have isomeric right appendages, we have bilateral sinus nodes, with isomeric left appendages, we lack a true sinus node. It is ventricular topology, however, that influences atrioventricular conduction axis, although in left isomerism, there is a high proportion of complete heart block. So let me now return to one of the questions I posed earlier in my talk. Because I said there are still some who like to call the arrangement of visceral heterotaxy situs ambiguous, arguing that the situs has not been determined. In fact, I've shown you that that is not the case. So is there any such thing as situs ambiguous? Again, not if we describe each system of organs. As I've shown you that the lungs, the bronchial tree, can show evidence of the usual arrangement, mirror imaged arrangement, or in those other individuals can be segregated into the right and left isomeric subsets. I've discussed with you splenic morphology, and you all know that individuals can have solitary spleens, they can have multiple spleens on either the right side or the left side, or the spleen can be absent. And I've discussed with you that that is not always correlating perfectly with the presence of right or left isomerism of the atrial appendages. Another key feature of the abdomen is what is going on with the intestines, and that is key to you as clinicians. So you need to describe whether or not there is malrotation. But as cardiologists, your focus is going to be on the heart. And now I've shown you that by taking the pectinate muscles, without question, we can distinguish between usual mirror-imaged right and left arrangements. But I recognize that that can still be difficult for you as clinicians. You cannot always recognize the pectinate muscles, but when you take everything into consideration, taking note of the venoatrial connections, I put it to you that the evidence is sufficient for you to make the necessary segregation, but remember the arrangements are not always in harmony. So does heterotaxy exist? Indeed it does. It is of considerable clinical significance. But what I hope I've shown you is that now, with the information you have at your fingertips, it is an easy matter to stratify those patients who are other than normal, who are heterotaxic, into the subsets of mirror imagery, right and left isomerism. And I hope I've been able to show you that when we judge isomerism within the heart on the extent of the pectinate muscles, then evidence of isomeric atrial appendages is unequivocal. I would stress again, however, it is only the appendages that are isomeric. So when we describe isomerism, Dr. Cohen is going to talk to you about right isomerism, left isomerism. I think that is entirely accurate. Within the heart, left and right isomerism reflects what is going on with the atrial appendages. Because the other cardiac features are variable. But that does not mean you should ignore them. All it means is that you should describe them as you should with the bronchial arrangement, the splenic arrangement, and when you describe all these features, when you take note of instances when they do not correlate one with the other, any ambiguity is removed simply by the process of description.
Norman, are you on?
Yes, hello. Thank you very much. I'm here. Well, that was really wonderful, Bob. It was clear as a bell. But I still think as clinicians, one of the problems with the atrial appendages is our inability to recognize the pectinate muscles. But I think you made this very important point about the terminal crest, which essentially subtends the pectinate muscles of the right atrial appendage. And I think that is recognizable in the fetus as early as 14 to 16 weeks. And so when you look at a cardiac exam and you look at the atriums and look at their appendage morphology, which may be different because of distension, as Dr. Van Praag had said, I think it's better to go and try and sort out the terminal crest, or the crista terminalis, as some of the listeners may understand it. So I think that that's a very important step in our echocardiographic recognition, because of the difficulty in recognizing the pectinate muscle surrounding the vestibule of the atrioventricular valve. So that's very important. The other issue that has worried me in the presentation that is difficult to understand is that although with all due respects to Gregor Mendel, there is one gene for one effect, there seem to be, besides that, a huge number of genes that seem to be involved in the process of segregating the heart in positions. And of course, I was going to ask you about this, but you emphasized it so well. What do you call the common atrioventricular junction in a patient who's got isomerism of the atrial appendages? And you already emphasized that answer as that is a mixed connection, because the one side is normal and the other side is discordant. So I think that was a very, very important observation that you made. But I wanted to ask you about this issue of primary ciliary dyskinesia and all of the genetic stuff which has been associated therewith, and the frequency of isomeric presentation when there is indeed ciliary dyskinesia. And of course, that also begs a whole lot of genetic material.
Well, thank you for those questions. I mean, in many ways, you've answered them yourself, because the problem with the pectinate muscles was really one of proving that isomerism existed within the heart. The same thing goes with the knockout that the molecular biologists did, proving that it was possible to create mice with isomeric atrial appendages. So I think what I've shown you today is simply proving that we can have right isomerism within the heart as opposed to left isomerism. And that, as you are well aware, you have lived through all this as I have. You have lived through us being told that there is no isomerism within the heart. Dr. Van Praag famously said that if the heart truly had left isomerism, then it would have 8 pulmonary veins. And that is taking the situation to ridiculous extremes, because as I have emphasized, it is only the appendages that are isomeric. The venoatrial connections are variable. They need to be described. I think the evidence now is overwhelming that we have proven that isomerism does exist within the heart. So in many ways, the problems that you describe, that you face as clinicians, are no longer a matter of looking for the pectinate muscles or looking for the terminal crest, because you know that when you are dealing with these patients, if you have ruled out the fact that they have pure mirror imagery, and that, I think, is another key consideration to take into effect, because mirror imagery is heterotaxy. So we have to rule out the cases that have true mirror imagery. They are the minority, in fact, of individuals with other than normal arrangements. So let's take those out of the equation. We're then left with a group of patients known to have so-called heterotaxy. You know, as clinicians, which of the two sets to put them in, because that is going to be, the differences are so huge. We know, for example, that in right isomerism, you're going to expect pulmonary stenosis or pulmonary atresia. That's hardly ever found in the setting of left isomerism. In left isomerism, the findings are not nearly as abnormal as they are in right isomerism. So you might have atrioventricular septal defect with coarctation, but it's most unlikely that you will have pulmonary atresia. In left isomerism, you know, the majority of patients are going to have interruption of the inferior caval vein. That is hardly ever seen in the setting of right isomerism. There is another key feature, because always the coronary sinus is absent in the setting of right isomerism. And you know full well, as echocardiographers, it's not difficult to recognize the coronary sinus. So if you recognize the coronary sinus and you know that your patient has so-called heterotaxy, the patient cannot have right isomerism. So what I have been saying today has been very much proving that isomerism exists within the heart. Having proven that isomerism exists within the heart, I would then put it to you that it is not difficult for you as clinicians, and remember that you are examining the whole patient. You're not just looking at the atrial appendages. I would put it to you that to you as clinicians, there is no difficulty nowadays in segregating heterotaxy into the right and left subsets. And that, to me, is the key, because the other point you've made, there is still concern at the moment about the genetic background to these things. We are never going to resolve what causes right as opposed to left isomerism if we put all of these individuals into the same basket when we are trying to assess the genetic background. We have to segregate them in order to find out which combinations of genes produce left isomerism as opposed to which combination of genes produce right isomerism. Because the key point here, there is no overlap. When you look at these individuals, there is a clear-cut distinction between right and left isomerism. You can make that distinction on a clinical basis. You have the chest X-ray to look at. You have abdominal ultrasound. This day and age, you know patients have which patients have multiple as opposed to absent spleens. The correlation is pretty good. That's not going to be absolute, but if you put everything together, I put it to you, there should be no difficulty in this day and age with 99% success to stratify heterotaxy into its right-left subsets. And that's all I am asking you to do.
Sure. I think that as an echocardiographer, as I look at this, one of the important issues is to look at when you see hearts with the types of a morphology that can be produced also in the mouse embryo, that you start thinking, well, could this be left isomerism or could this be right isomerism? And start looking at the appendage morphology and the other associations to establish it, because once you start thinking along the lines of left isomerism or right isomerism, the diagnosis often falls into place like a pack of cards. So I think that's a very important issue to look at all of those features, and to realize also that the secondary characteristics like the venoatrial connections and the veins are often present, but not always present. And one of the problems in the literature, when you try and read this, and I'm sure many of the viewers will be trying to read the literature, and you come across papers where they say, we defined left atrial isomerism by an interruption of the inferior vena cava with azygous continuation. That is not going to give you all of the pathology that you see, because they're missing the key point, which is to look at the atrial appendage morphology.
You're right, that in certain circumstances we are going to find difficult cases, but I think we can sort it out if we look at the questions that have been asked, and we have several questions that relate to those comments that you've just made. So here we have one, what about left inferior vena cava vein and left isomerism? As you say, we anticipate that that is going to be there, but it's not always there. And very rarely we will find it in the setting of right isomerism. But if we find an interrupted inferior caval vein in the setting of right isomerism, if we look at the bronchial tree, almost certainly the bronchial arrangement is going to be that of right isomerism. We have another question as to say, should we say atrial as opposed to atrial appendage isomerism? Not if we want to be precise. If we say the patient has left atrial isomerism, we fall into the trap that was laid for us by Dr. Van Praag, because he would then say if there's left atrial isomerism, there are 8 pulmonary veins. If we say there is isomerism of the left atrial appendages, we then explain what is going on with the pulmonary venous connections. And oftentimes, as you know very well, Norman, they are symmetrical. There are two pulmonary veins going on at either side, but that's not always the case. We can have 4 pulmonary veins to the left-sided atrium, 4 pulmonary veins to the right-sided atrium. It is exceedingly rare in the setting of left isomerism to find totally anomalous pulmonary venous connection. Indeed, I've never seen that association. We have another question here. How do you classify the central liver? Well, the liver is independent of isomerism, and indeed, we have now come to appreciate that isomerism affects the thoracic organs. There are associated malformations with the abdominal organs, but it is very unusual in the abdomen to find true isomerism. So oftentimes the liver is indeed central. That doesn't give us any clue as to whether there is right or left isomerism, but the liver is not always central. Sometimes it's in the left side predominantly, sometimes it's in the right side. We have to describe that, and we then have to integrate that into our overall clinical analysis. We have another question here. Have we found a higher frequency of endocarditis in hearts with right isomerism? This all relates to the influence of the spleen and whether there is a lack of immunity. And indeed, even when you have multiple spleens, that reduces the immune response. So endocarditis, I can't give a perfect question to that, answer to that. I mean, do you know the answer to that, Norman?
No, I don't. But capsular organisms are a problem throughout life. It's the inability to fight with antibodies, the capsular organisms of pneumococcus, of Haemophilus, and of the Neisseria group. And so they have a high incidence, and patients with right isomerism or any patients with left isomerism that don't have a spleen require this antibiotic prophylaxis throughout life. So I think that's important.
And then we have another question here. Can pectinate muscles be recognized by CT, CMRI? Certainly by computed tomography. It is an easy matter in the images that I have been shown by computed tomography. And it is my belief that very shortly, you echocardiographers are going to be struggling for business, because it's going to be an easy matter to put all the infants into the CT scanner. The radiation dose can now be reduced to virtually 0, and you will have instant gratification. But we won't go into that because I wouldn't want to put you out of business. So we then have another question. Appendages not always visible on TTE. Do you always need TTE to confirm your diagnosis? Norman, that's one for you to answer.
CTE is what?
TTE, transthoracic echocardiogram. So I presume he's at TEE. Do you need transesophageal echo to confirm the diagnosis?
I was just thinking of all of this with regard to size, because when you have a small patient or a fetus, obviously you can't do transesophageal. But in the small patient, the quality of the transesophageal echo is somewhat limited. because the transducer cannot have an appropriate number of elements on it to make a scan. And I think also the same is true of the CT scan. The CT scans where you can make the diagnosis of pectinate muscles, which I'm not denying, is much easier in the larger patient, but it's much more difficult in the very small patient. So I still think that in the end, we're going to have to rely on echocardiography quite strongly for recognizing these abnormalities. And of course, if you then do the intravascular ultrasound, there the pectinate muscles are very close and you can easily recognize where the pectinate muscles are, and the electrophysiologists are using this technique for their studies, but it's not generally used by ultrasound clinicians.
We have another good question here from Vera from Sao Paulo, who asks, do I believe that the disharmony between thoracic and abdominal arrangement is only a consequence of difficulties to recognize the lateral structures, or does it exist also in the setting of direct observation? Well, absolutely it does. I mean, that's what we found in Uemura's study. So in Uemura's study, we showed, I think, that the correlation between the bronchial arrangement and the appendage arrangement was about 90–95%. I showed you in the spleen, the correlation was no more than 4/5. So there were lack of harmony in about 1/5 of cases. And we know in the clinical setting that with what you can see clinically, that in maybe 1/5 of cases, there is going to be disharmony, but in no way does that disqualify the fact that we can segregate them as having right or left isomerism. It simply will find isomerism in the different sets of organs. There was another question of what do I think about the term isomorphism? That is a new one to me. I've been accused throughout my career of changing the names so I can write more papers. I wouldn't want to introduce yet another term when we have yet to establish the importance of isomerism. So I think isomerism works remarkably well. I think I've shown you that there truly is isomerism within the body, within the heart. And let's not try and complicate it by introducing still new terms. So
well, can we use the term isomerism rather than left atrial isomerism or left atrial appendage isomerism when we talk about this amongst each other and understand what we're talking about?
So what you're saying, you simply say left and right isomerism?
Yes.
Yes, I agree. And that is what Meryl is going to be promoting when she talks next week. I have no problem with that at all. And indeed, on occasion, you can have isomerism, left isomerism of the thoracic or the abdominal organ, or abnormality of the abdominal organs without having isomerism within the heart. So biliary atresia, for example, is an example of isomerism, but that typically is found with normal atrial arrangement. So the heart does not necessarily follow what's going on with the lungs and what's going on in the abdomen. We have to, the point I'm trying to make is that we have to analyze each system of organs in their own right. And if we do this, we take away any question of ambiguity, but we recognize the importance then of isomerism, and it's distinguishing the two subsets of isomerism that then brings clarity into so-called heterotaxy.
So Bob, if I may talk about your very good friend, Bob van Meerop, who many years ago, and I think this is an important clinical point, described juxtaposition of the inferior vena cava and the aorta on the same side of the spine. And I think this is very important for clinicians because usually it's the inferior caval vein which has to cross over. And if you want to get a surgeon angry, you won't find where the position of the inferior vena cava is, because when he's doing a Fontaine procedure, he's got to look for the inferior vena cava, and it often crosses the midline. And so it's very important to recognize the inferior vena cava, where it lies, and how it actually makes access to the atrium as a clinical point.
Indeed, and I mean that you will remember that was one of the original ways of recognizing isomerism. And Geoffrey Smallhorn was one of the first who pointed to that importance. And then Jim Huter took it on when Jim spent time at Great Ormond Street when Smallhorn was still at Great Ormond Street. And Huter then took it back to Houston and popularized it in your country. So I agree with you 100%, recognizing the juxtaposition of the caval vein and the aorta in the abdomen is key to distinguishing. And that is another useful surrogate and another way that you as clinicians can recognize and distinguish between the two subsets. Absolutely.
Good.
Ekrid, is there anything I haven't answered?
Perfect answers. I love it. And I think I have one more question here. VD Aiello. Do you believe that this harmony between the thoracic and abdominal situs is only a consequence of difficulty to recognize the lateralized structures in the living patient, or it does exist also in the setting of direct observation of the internal organs?
I think I answered that one already, in fact. You might have missed me saying that one, that it is a real thing. And that's what I was saying. In about maybe a fifth, maybe a tenth of cases, you would anticipate some disharmony between the arrangements of the organs. And that is a real thing. It's not just that you're mistaking them with the diagnosis. There is true disharmony. It's not, we should not think, we should not even expect that when you get isomerism, it's an absolute finding. We have to anticipate that the different sets of organs are responding in different ways to the combinations of the genes that Norman was talking about.
Yes.
Well, while you're talking about genes, can you perhaps enlighten us on the fact that if you look at series of left and right isomerisms, you'll find that there's a common atrioventricular junction and a common atrioventricular canal in both groups, but it's more common in right than left. Can you enlighten us on this, please?
Well, these are the things that as yet are unknown. I mean, I make no claim to be an expert in the genetic background of these things. We're beginning to understand, however, as to why you have common atrioventricular junction. We know it all depends upon the formation of the vestibular spine or the so-called dorsal mesenchymal protrusion. So when we begin to unpick the genetic cascades in the two subsets, we can look for those genes that are perhaps perturbed or deranged in both subsets. And then we will find why it is, as you say, that some have a preponderance of this feature, others have a preponderance of that feature. At the moment, we can intuitively think why it should be. But as I emphasized, if we continue to put everybody in the same bucket, we're never going to separate out the two subsets. It's like apples and pears. Until we separate apples and pears, we would never have known which genes make an apple and which gene makes a pear. And I think it's the same for left and right isomerism, and which genes are common to the two and which genes modify the effect of what we know. I mean, we can pinpoint PITX2 as being responsible for leftness. We can pinpoint the midline genes, but the other point you made, these work as part of a much bigger group. So working out the way they interact with each other, we need to separate out the patients, and then we can perhaps even segregate them even better. So we can take patients with right isomerism and AV septal defect, patients with left isomerism and AV septal defect. And if we have big numbers, we can do genetic analysis of the whole of the patients and see which genes are similar, which genes are different. But we'll only get that when we start segregating them according to the phenotypic features.
Right. Thank you.
I can say that I'm so happy to stay here now, and I want to say that I'm so glad to know you, Dr. Robert, because here in Brazil, everybody loves your book. And I want to say bye for everyone from Brazil, and we'll see you on Monday with Professor Cohen. And thanks for Sasha, Dr. Norman, Dr. Robert, and all the Congenital Heart Academy to the opportunity, and Grace too.
Okay.
Thank you very much.
Thank you. Thanks very much, Bob. Great job.
Thank
Enjoy.